Hi, and welcome to the VieSID Press-release. In this video, we report on articles selected from the dental literature published in June and July 2022 that we hope might be of interest to the VieSID community. So let's begin. In the Advanced Dental Technologies and Techniques, Radke and Sutter describe the joint vibration analysis, a method for the detection of TMJ internal derangement. You see the necessary equipment in the figure. The joint vibration analysis consists in recording vibrations from within the TMJ through accelerometer, while the subject opens and closes from the maximum intercuspation to maximum comfortable opening, evaluating the intensity and frequency content of the vibration from multiple measurements and comparing also the left and right joints. The outcomes can be then compared to reference values. According to the authors, based on the detected parameters and the waveform, the TMJ condition can be determined with very high specificity, up to 98%, and good sensitivity. For example, 92 to 97% sensitivity for internal derangement with and without reduction can be expected, while perforation and TMJ degeneration alone or in association to this displacement can also be reliably detected with sensitivity ranging between 87 and 100%, depending on the condition. The total time required to apply this analysis is usually only a few minutes. There are no consumable costs, and the recording of the data is usually accomplished by auxiliary personnel. Thus, the authors concluded that the joint vibration analysis can be used as a screening tool to assist in decision-making as to whether MRI or CBCT are necessary for the diagnostic process. The Annals of Anatomy published a review by Akita and Fukimo discussing the anatomy of the human masseter and temporalis in response to a work by Mesi et al., published in the same journal, which we reviewed in the VieSID Press-release of December 2021. Mesi et al. Described the third layer of the masseter muscle running from the medial surface of the zygomatic process of the temporal bone to the root and the posterior margin of the coronoid process with diagonally running fibers, suggesting that it stabilizes the mandible by elevating and retracting the coronoid process. Mesi et al. Named this muscle coronoid part of the masseter. Akita and Fukimo, in the current paper, claimed that the coronoid part of the masseter was already described in the literature in different ways, as a part of the masseter, as an independent transitional muscle bundle, or as a part of the temporalis, and was named accordingly as zygomatic mandibularis, the deep part of the masseter, the maxilloromandibularis, or the accessory head of the temporalis. As Akita and Fukimo noticed, based on the dissection of one cadaver, some of its fibers might be in common with the temporalis. They also reported that in 1999, Shimokawa et al. Concluded that the muscle bundle is an independent muscle based on the fact that no innervation is shared with the masseter. However, this account clashed with information reported in the recent Masi et al. 2021, where masseteric innervation of the coronoid part was clearly and consistently identified. Given the accurate and comprehensive evidence they collected using sophisticated approaches, I would conclude that the evidence presented in Masi et al. Is persuasive over the previously published papers. Thus, while the paper by Akita and Fukimo does not invalidate the conclusion by Mesi et al., it has the merit to contribute to the narrative about the masseter layer structures. Javed and colleagues published a systematic review in the Archives of Oral Biology exploring the effect of testosterone on orofacial nociception. It is known that male and female experience pain differently. Similar TMD is more frequent in females than in males. Testosterone, together with estrogen and progesterone, has been proven to influence nociception. Moreover, estrogen and progesterone decrease the quantity of collagen and proteins in the TMJ disc, while testosterone increases it. The authors included 7 articles using rat models in which pain was induced via complete Freund's adjuvant, which induces inflammation, tissue necrosis, and ulceration. In these studies, testosterone was administered subcutaneously in variable concentrations ranging from 1 to 10 milligram per kilo. Pre- and postoperative nociception in these animal models was assessed by examination of rats' behavior, such as rubbing or facial region with the paws or head flinching. All studies confirmed that testosterone administration in gonadectomized male rats reduces induced TMJ nociception. In particular, Torres-Chavez et al. In 2012 showed that testosterone reduces inflammation level, while Macedo et al. In 2016 concluded that the protective effect of testosterone on TMJ nociception is mediated by activation of central opioid mechanism. So despite a high risk of bias read in the figure is prevalent in the articles analyzed, the authors discuss the possible therapeutic application of testosterone, which is surely not free of obstacles. It suffices to consider that testosterone is classified as a doping substance, but local use of testosterone is a possible avenue to explore, according to Javed and colleagues. The European Journal of Dentistry published a systematic review by De Moraes Meloneto et al. On the reproducibility of bimanual technique versus chin-guided technique for obtaining centric relation based on 6 papers. 3 of these found that the bimanual technique allowed for greater reproducibility of condylar position. 1 found a chin-guided technique superior to the bimanual technique, and other 2 did not found any difference between these techniques. In sum, bimanual manipulation might seem preferable to chin guidance, but the outcomes are not clear-cut. In fact, the authors warned about the limitations of the available evidence, which did not consistently control for operator and thus applied forces, position of the patient, supine or seated, and also time of the day in which the recording was taken. Additionally, muscle deprogramming was not consistently performed, and its length was mostly not reported. In the same journal, Silveira et al. Published an article referring to the work of Pedro Planas, neuroclusal rehabilitation, published in 1987, discussing Planas development laws. This paper focused on the law of minimum vertical dimension, which states when the mandible moves to reach the maximum intercuspal position, this always involves bringing the mandible and maxilla as close together as possible. Although this seems an obvious statement, this observation becomes relevant when the occlusion is not balanced. According to Planas, in physiological occlusion, we should expect that from rest position, the mandible closes until the first occlusal contact is reached. The first dental contact should coincide with maximum intercuspation and thus correspond to functional occlusion. An asymmetric vertical dimension, shorter on one side than the other, leads to unilateral chewing on the shorter side with unwanted consequences for the TMJ and for the face development during growth. In this paper, Silveretta and colleagues explored the literature to find evidence supporting the Planas minimum vertical dimension law and highlighted the functional and clinical consequences of an unbalanced occlusion, including lateral deviation of the mandible, unilateral crossbite, premature contacts, all potentially leading to TMJ dysfunction. Allow me to comment on the fact that the law is a general rule or idea that adheres to the nature of the universe. Thus, Planck's laws should be better referred to as principles, namely specific phenomena that require an explanation. Furthermore, until a principle is not tested and demonstrated, it remains an hypothesis. Although I think the relationship between malocclusion and TMJ dysfunction is unquestionable, it is necessary to conduct dedicated studies to test the effect of asymmetric vertical height, its relationship with the preferential jaw inside, the TMJ condition, and kinematic of the jaw, ideally establishing directionality of causality. In Japanese Dental Science Review, we found an article by Gasparro et al., which is a systematic reviews and meta-analysis of systematic reviews evaluating the validity of various approaches for the acceleration of orthodontic tooth movement. The authors analyzed 28 systematic reviews considering corticotomy, piezo-scission, and micro osteoperforations. Of these, 6 presented a high risk of bias, while 12 were of high quality. Although the title of this article announced a meta-analysis, the heterogeneity of the research did not allow carrying out such analysis. In fact, many factors varied in the surgical techniques and instruments used, the position and extension of the perforation, the presence of additional bone grafting, or periodontic treatment. Based on this review, the authors concluded that corticotomy was found more consistently to produce favorable outcomes as compared to conventional treatment. Instead, for piezo-scission, micro-osteoperforation, and cortico-piezo-scission with graft, the review delivered conflicting results. Thus, no definitive evidence was found supporting the use of these procedures. At the same time, the authors discussed the complications reported during or after the surgical procedures like pain, swelling, temporary paresthesia. In conclusion, shortening orthodontic treatment time might be convenient, especially in adults, and might be recommended to reduce clinically heterogenic effects of orthodontic treatment, such as loss of dental support or increase in dental caries. However, based on this review, it is apparent that numerous factors should influence the decision of the clinicians as to whether accelerate orthodontic tooth movement and how. It goes without saying that a high level of clinical expertise is necessary to apply any of these techniques. We've come to the end of this presentation. I invite you to contact us in case you want to know more about our activities. Otherwise, be ready for next press release. Best wishes to all.